Good.
This be you?
So the next page is my disclosures, if you want to pop through that.
Huh?
Learning objectives. The first thing I'm going to do is actually not directly about activities, but just a little bit of education about the term that's probably most appropriate to use for the folks that you'll be working with, and that is cognitive communication disorder, or CCD. And so when I talk about the difference between aphasia and CCD, recommendations for therapy tasks, importance of care partner training, role of memory, attention, and executive functioning in language and communication, and tasks to improve communication in CCD. Next slide, and I'll just go ahead and also have the disclaimer. I have way more slides than we're going to cover, but I wanted to give you lots of tools. So some of them are just sample therapy items, and I won't dwell there. I won't spend a lot of time, but they're for you to revisit later. So just really briefly, just wanted to talk about the difference between the types of communication problems that happen because of focal left hemisphere damage, specifically that which follows your cerebral vasculature. And that's going to lead to the types of aphasias and language problems that are probably more comfortable for you. We know a lot more about it. We know, at the very least, even if you don't know subtypes, you know that there's some people receptive or expressive, or some people say fluent or non-fluent. But depending upon where the damage is, and where it's, which arteries have been impaired, you're going to have a certain type of behavioral presentation of symptoms. And we have a pretty good strategy for dealing with those symptoms per subtype. So the problem is that a lot of that thinking, a lot of even that testing for language deficits that we expect after stroke, we're using that same testing and we're using those same approaches for TBI. And it's not going to be very helpful. So if you could move to the next slide, when we have diffuse brain damage, for example, as a result of closed head injury, that's when we're going to more likely have a cognitive communication disorder and not aphasia. There's a little bit of either reverb or something. I'm hearing some other things. Could someone check that out?
Yeah, let me see if I can just turn my mic off. Right, yeah, hang on, I gotta go find this and go to there. And then.
So it's a perfect example of how attention is impacting my ability to communicate successfully. So yeah, thank you for going back to that slide. So in the case, for example, of closed head injury with linear and angular acceleration, I'm not telling you anything new, but we know this commonly leads to diffuse axonal injury, and there are actually quite predictable patterns of damage to surface areas of the brain as well. So we know because of the inside of the cranial vault that ventrolateral anterior surfaces of frontal and temporal lobes is present alongside the diffuse axonal injury. So as you know, from this we get slowed information processing, impaired working memory and attention, executive functioning problems, and communication disturbances that arise from those different cognitive problems. So if you can go to the next slide, I'm defining CCD for you. So cognitive communication disorder is defined as communication impairments resulting from underlying cognitive deficits due to neurological impairment. These are difficulties in communication competence, listening, speaking, reading, writing, conversation, and social interaction that result from underlying cognitive impairments such as attention, memory, organization, information processing, problem solving, and executive functions. And the reason that we have this term is to really get people out of the aphasia box, because it's not serving our people who have brain injury that is somewhere else besides focal left hemisphere. So if you can go to the next slide. Again, this is used to differentiate communication disorders resulting from primary cognitive impairments from those that are from primary language impairments. It's based on the premise that in these folks with CCD, that basic language functions such as syntax and semantics are intact, which is in contrast to aphasia, where the problems with the basic language functions of syntax, semantics, form, phonology, that's the defining characteristic of that disorder. And CCD is not aphasia, and we need different approaches to assessment and a treatment. And so that's what I'm trying to bring awareness of here. We know that, again, CCD has unique features from aphasia, unique comorbidities, unique trajectories of change over time. This is just to also kind of respond to you, Mark, and like, where does communication come into play with cognition? What are the roles? What are the interactions here? We know that to be a successful communicator, you are not only tapping into form and structure and content, you're also tapping into a lot of cognitive components, such as attention, comprehension, working memory, long-term memory, self-awareness, inhibition, planning, monitoring, all of these things. So to be a successful communicator, you really need to have each of these three boxes completely intact. And when you start to have some slippage there because of different types of brain damage, you're going to have some problems with communicating. If you go to the next slide, these are just some words that are used to talk about our TBI patients. So you can probably see these words and immediately think of a patient that's on your caseload or in your clinic or in your lab. They might be described as overtalkative, perseverative, inefficient, slow, humorless, confused, very literal, disinhibited, confabulatory, have impoverished content. They may drift from topic to topic. They may just be very flat, tangential, inaccurate, confused. So just really quickly as a check-in, how many of you, if you can either raise your hand on the screen or say something in the chat, how many of you have people who are described by two or more of these words? I see some hands. So, and some of us may even describe ourselves with some of these words. What's become very clear is that these patients have communication problems, and these communication problems interfere with their everyday lives. What has also become very clear is that traditional language tests like aphasia batteries or bedside screens of language, they are not sensitive to these communication impairments. They're not picking them up. And so what we have is a lot of descriptions of things that happen after you have TBI. We also have a lot of collective community knowledge about, hey, report that the main reason they can't have friends or get job is because of these communication issues. But we haven't really had good ways to assess or treat cognitive communication disorder until very recently, when it's being recognized and built. If you go to the next slide, one of the main things that we're advocating and pushing for is discourse analysis measures. These are easy to give, and my lab and others have developed clinician-friendly ways to score them so that you're not having to do phonetic transcription, which nobody's got time for that. So ways to look at discourse performance, look at cohesion, look at coherence, so that we can capture some of these cognitive communication deficits that would not be captured, again, on a traditional language battery. What we do know is that discourse analysis measures consistently reveal significant difference between PWAs, that's persons with aphasia, and controls. And we are also recognizing that discourse analysis is increasingly important for being able to identify and create a treatment plan for people with cognitive communication disorder because of TBI, and in some cases, in many cases, right hemisphere disorder as well. So when people have stroke to the right hemisphere, a lot of their communication problems look exactly like a TBI. We know that discourse is the foundation for everyday interactions, functional conversations, and fulfillment of life roles. And it's likely going to be one of our better candidates for predicting outcomes that matter most to the patient. So if you go to the next slide, when we actually ask patients with TBI what they want to work on, we see that discourse, working on assessment and treatment of it, is more in line with what people with CCD want. So I have just listed here a couple of different stakeholder perspectives when they were asked what were the most important goals. This was a survey that was conducted a couple of years ago. Health professionals wanted individuals with TBI to use communication to get basic help. That sounds pretty standard, right? Communication, basic wants and needs, tell us when you need help. Family members wanted individuals with TBI to work on listening and concentrating. People with TBI said what they wanted to work on was to work on skills related to interviewing and communicating in the workplace, skills related to making appointments, having social conversations in groups, writing their thoughts, speaking slowly and clearly, asking questions, and using the telephone. So when we actually ask the patients what they want, we get a pretty good idea that it's not about crossing out certain shapes on a piece of paper. It's not about communication of basic wants and needs, about toileting or anything like that, that we're talking about life-enriching communication interactions are at the top of the list for people with TBI, whether or not they have cognitive communication disorder. Hopefully that will spread the word about that and spread words about activities to do. The next slide is just a picture that's showing recent recommendations that came out in 2014, and these are quite good, and I recommend them for other areas as well. So this was kind of after the ACRM published their manual for cognitive rehabilitation. This group got together, which actually included a lot of people from ACRM, to give information that was exclusive to the TBI population, that was freely available, which the manual is not, and that provided very specific audit criteria about how they came about their recommendations. And they formed an international panel of experts in cognitive rehabilitation after TBI, referred to as the INCOG team. And so they have these different articles in the Journal of Head Trauma and Rehabilitation. And as you can see, some of them are on delirium, attention, information processing speed, executive functioning, and impaired self-awareness, and memory. How many of you, by show of hands or chat, how many of you are familiar or have run across these or used these recommendations? Okay, so I see folks in the echo room, but I didn't see too many other hands there. The one where we are visiting here for this talk is the one specifically on cognitive communication. So if you can go to the next slide. And this is led up by my colleague, Leanne Tower, who's fantastic. She's doing amazing work down in Australia with TBI and with different types of service delivery, with communication partner training, just a whole lot of amazing, exciting work down there. So I'm just going to walk you really quickly through just the main recommendations. Of course, I encourage you to visit these papers. If you have difficulty, if there's a paywall for you to access these articles, please address here in the chat, and I'm happy to mail these to you because everyone needs these articles. So I just put my information in the chat. So if you can go to the next slide. Again, just listing very broadly, just for time, we don't have tons of time. I want to get to more examples than anything else. But the first recommendation is that rehabilitation staff should recognize that levels of communication competence and communication characteristics may vary as a function of communication partner, environment, communication demands, communication priorities, fatigue, and other personal factors. And some of these recommendations are like, well, yeah, of course we know these things, but a lot of people don't know these things, and it's kind of sad that we've had to actually put them in a list of recommendations in some articles, because some of them are like, okay, of course we should be thinking about these things. The example that I have for you here that I pulled out was, for example, the communication partner's level of experience in interacting with people with cognitive communication disorder can affect the nature of the interaction. So it's not just about the abilities of the person with the brain injury, it's about the abilities and the competencies and we also know through several RCTs now that conversational skills training for partners can improve the interactions of the person with TBI. So not even focusing on the person with TBI, but focusing on a conversational partner improves their outcomes, their conversational abilities, reveals their competence, and improves their everyday performance. Another example specific to kind of communication characteristics and environment and demands is that a person with TBI may do much worse in situations where a time pressure is applied or when there are many distractions. And so later on when I get to some tasks, I'll kind of bring that back up again. If you can go to the next slide, the second recommendation is that a person with TBI who has a cognitive communication disorder should be offered an appropriate treatment program by a speech-language pathologist. And again, it seems kind of silly to say this, but actually the recognition of the SLP's role in persons with TBI and cognitive communication disorder, it has not been widely recognized until very recently. So we're talking early 2000s was the first time that we had the realization that SLPs are uniquely trained to deal with these types of disorders, and we're starting to be brought onto teams. And I think probably you could also agree that we're still having problems and barriers to making sure that that happens for our patients. That we may have someone who has difficulty communicating, but we're not quite sure what to do with them, and there's not a natural existing relationship with an SLP, or there's not an SLP with the skills to deal with this type of population. And so we still have a lot of barriers there. Am I talking too fast? Mark, can you nod or? Okay. So the third recommendation is that a cognitive communication rehabilitation program should take into account premorbid native language, literacy, language proficiency, cognitive abilities, communication style. And I love this last piece, including communication standards and expectations in that individual's culture. This is also something that we're terrible about. Most of the assessments that we give are not appropriate either in the stimuli that we're presenting or in the norms for use with people with any sort of cultural and linguistic diversity. So I like that this is kind of front and center. The example that was given was from New Zealand, where they had Maori TBI participants. They rated their priorities as participating in a specific cultural protocol, self-expression through art and craft, and communicating in a sports team. That was at the top of their list, whereas employers ranked the ability to answer questions as the main concern. So again, kind of thinking about person-centered goals, thinking about which stakeholders are we talking about here. Just as a note, in the future, I would love to talk about goal development more as well, person-centered goals. So I guess we'll talk about a date when we can do that. So if you go to the next one, this is recommendation 4. A program should provide the opportunity to rehearse communication skills in situations appropriate to the context in which the individual will live, work, study, and socialize. Again, our standardized measures are not going to capture this, and they're not going to predict it. So, for example, if we give a language measure, a basic communication measure, a lot of our folks with TBI will ace those measures. They will ACE, the aphasia batteries in most cases, do really well on them. And it's not going to predict how they're actually going to be able to communicate. And then if it does have any sort of predictive power, maybe it's predictive power like in the laboratory or clinical setting, but not in everyday life. So another thing about this population, as you very well know, is that persons with TBI have a lot of difficulty transferring skills, generalizing skills to other environments. So again, this is just a basic treatment gold standard. We want to make sure that we're doing it where it matters, but that's also very hard to do logistically and for our schedules. So, but this is a recommendation. There are also lots of recommendations out there that exist for like how to make this happen through telehealth, through maybe they're doing things kind of offline and then they're coming back and you're doing some metacognitive work with them. The other thing is there's been a couple of trials where if they have daily homework that involves conversational interactions, they have better outcomes in terms of social skills and community integration than if they do not have a daily program of conversation embedded into their programs. If you get to the fifth recommendation, this is about communication partner training. We definitely know that communication partner training is important and can improve the outcomes and the quality of life of people with TBI. So we know that social networks shrink significantly. Contexts that remain will usually include family, maybe a few close friends if they're lucky, but a lot of people don't report any close friends. Healthcare professionals, in some cases paid carers, people in the community, including people who may specialize in working with people with disability, and law enforcement. And that's also something we know that a lot of our people with TBI have difficulty with, and they need ways to advocate for themselves and to explain to law enforcement that they have a brain injury and that they have difficulty communicating. At the same time, law enforcement for people to have that say, you know, I have traumatic brain injury, we have it with stroke, you know, we have it, you know, something that they will have on their person. But if you have a law enforcement personnel who doesn't care, that's not going to help. Lee and Tower actually, they started this fantastic program called TBI Express. And as their first phase, they trained police officers. They found that just training the police officers on what TBI was, on communication strategies, resulted in more efficient and focused communication. Then they, as a follow-up, they trained family members. They had improved conversations, and these changes were maintained. And then they trained paid carers, and similar results. So again, this is training that's happening off of the person with TBI. It's training in the community, it's training in the family. On the next slide, I kind of point you to this resource. They have videos, they have training videos, they have training manuals, and they're a fantastic resource that you can also contact for more information about communication partner training, specifically for people with TB, for the carers and family members and friends of people with TBI. Sorry, the allergies are kind of messing up my voice. So the next recommendation is that is an AAC recommendation. I'm not really going to spend a whole lot of time here. That kind of deserves its own separate one. If they're very severe and their communication is so severely impaired that they require augmentative and alternative communication, then they absolutely need to get the appropriate help with SLP and or OTs for that. The next recommendation is number 7, is again kind of circling back to that patient-centered, person-centered. We need to address patient-identified goals for social communication deficits with outcomes measured at the level of participation in everyday social life. And the evidence is strongest for group settings. So for interventions that provide a group so they can actually work on their social communication in a group setting and not just one-on-one. And I just bring up the WHO ICF figure here. so that you can kind of see how this exactly fits into activity limitations, participation limitations, and just as a note, the care partner training fits very nicely with the contextual factors, because then you're going to be modifying one of the environmental contextual factors that would improve the person with TBI would improve their life. The next recommendations are in line, but these are recommendations from the ACRM Cognitive Rehabilitation Manual and also the Cicerone article that hopefully will be updated soon. I'm giving you some recommendations and then some sample tasks in the communication domain. And then what I will do is show you how some of the recommendations for attention and executive functioning that are more geared towards neuropsychologists to administer, they can be developed in such a way to also work on their cognitive communication disorder. And so I'm going to show you both of those things. Again, this is where I have way too many slides because I was trying to show you kind of like sample items and things like that. So this is something for you to revisit later as well. Just to briefly orient the way that the Cicerone article gives the guidelines or the recommendations, and that's what EBR stands for, evidence-based recommendations. You could also call them CPGs, which are clinical practice guidelines, but they present them with what had the highest evidence is practice standards, medium evidence, and there's specifics about what constitutes this as practice guidelines, and then practice options. So at the top is going to be our standard, and then our lowest evidence is going to be our practice options. But for communication, they do recommend, especially in acute and post-acute stages, cognitive linguistic therapy that can include a number of things. Show you some sample goals and tasks to improve social communication skills. As a guideline, if they do have a specific area of deficit, for example, reading, word finding, discourse production, then definitely target that specific area. Treatment intensity was also shown to be a very key, important factor. They need to have more practice, and this is something we want for all of our patients, really. As a practice option, according to this recommendation, group-based intervention for language and social communication deficits. Remember, though, that according to the INCOG recommendations, group had the most evidence. So we've got two different streams of information, but both of them are saying that groups are important. And then anytime that you can have computer-based interventions as an adjunct to complement whatever the clinician is doing, that's going to be a good recommendation as well. So the next slide, there's different types of tasks. You can work on social skills training, narrative, conversation, script practice, social skills scripts, and memory and attention during conversation. So you'll see what I have next here is even just an example of goals on the next slide, just kind of even long-term goals and short-term goals. Having shown you this, I'm not one for like a cookbook of goals. I adhere to that, but these are good for inspiration. And so just wanted to make sure I said that so that I'm consistent with how I usually teach about these things. But it gives you a good example. This is talking about self-monitoring. So we're really wanting to have them maintain the topic to make sure that people are getting equal opportunities during conversation, to use pausing appropriately. So there's different strategies that can help with conversation maintenance and conversation repair. So these are some example goals that we would have for a patient who had that difficulty with conversation. For the next one is about emotions, actually, and we know that a lot of our folks have difficulty with the emotional aspect, emotion recognition, facial expression recognition, as well as the stress and intonation or the prosodic contours of speech that also lend a lot of emotional valence. So people with TBI have a lot of difficulty with this. So one goal might also be to identify common emotions based upon facial expressions. So that's another example of some tasks that we would do. For the next slide is the auditory emotion. So this is, again, working on those, how our nonverbal or our non-linguistic information that we're providing. So, are they able to determine, the sun is shining today is happy versus the sun is shining today as sad. And so there's lots of different ways to have them recognize auditory information that is related to emotions. The next one is just a different type of tasks, and this overlaps a lot with memory tasks that you may be doing as well. So again, something that could easily be employed with a neuropsychologist treatment program that had a primary goal of memory, doing memory for paragraphs of 3 sentences or 4 or more sentences, and this would be an example of a type of task that we do to work on that. Another task is how to choose the correct information. So this is the next slide. We give them some options, and all of these, I don't give these as a worksheet. I use these items to then have a conversation with my patient. So we'll talk about calling the repair shop to see if your TV can be picked up, which message should you leave on their answer machine. Again, these are for more severe people with communication problems or more severe communication problems, but this is an example of some tasks that we would do if someone isn't always appropriate or doesn't know how to get straight to the point in their communication interactions. Another one is writing messages. So if you have, you heard a couple of different pieces of information, what's the essential message? What's the gist? What's the essential content of that message? Could you really get out what you needed to get out from this sentence or set of sentences or communication exchange? Again, another thing that we do on the next slide is condensing information. So they get more information and they have to condense it down to the essential elements. And our folks with TBI and CCD have a very difficult time with this, really across the severity continuum. The next one is drawing conclusions from word problems. So, there are details that are there. There's also some things that are implied. Are they able to work with both the details and implied information to come up with something, a conclusion that is correct? The next few slides are about feelings. So we might have them have lots of conversations about inferring feelings from statements and trying to match a feeling to a different type of statement. You can do this with written. You can also do this with audio. We do a lot of ours with audio as well. And then sometimes we'll also have them try to produce so that you tell them a statement or even have them count to 5, but they need to count to 5 as if they're happy. Can anyone do that right now? Can you count to 5 as if you're happy? 1, 2, 3, 4, 5. Or you can be surprised. 1, 2, 3, 4, 5. Or you can be angry. 1, 2, 3, 4, 5. So I know it's silly, but our people with right hemisphere and with TBI, they can't do that because those basic emotion processing circuits are busted, for lack of a better word. On the next slide, again, inferring feelings from actions. So Mr. Davis picks up his car for repairs. There's no charge. Is he delighted, disappointed, or hysterical? So just kind of really navigating feelings with situations in this case. And again, the next one on the next slide is identifying feelings in given situations. And this, we're up a level now. They don't get multiple choices. They have to fill it in. And then you have a conversation. Well, why do you think that you feel this way? And you get to correct if they're way off in the emotions or the feelings that they're describing. Also, a lot of folks that we have, again, very literal, difficulty with abstract language, difficulty with humor. So on the next slide, you'll see that we may even actually target humor specifically. Some people, when we've asked them what they want to work on, they want to tell jokes again, or they want to feel like they can laugh in conversation without faking it. So we help them very directly to work on this. So you can see some examples of solving riddles and, choosing a humorous answer. Some other activities that we do involve job searching, so simulating interviews, doing a meta. This is an older book, so there's a new one, but it's actually got some really great tasks in it. But it's got a lot of examples of how to navigate that whole job search process. And as any of you know, all of us are professionals, so you've had the interview process, or you're interviewing people right now, or there's constantly people that you're interacting with about employment, and there's a lot of communication that if you miss the cues, and if you don't do it right, you're not getting that job. So a lot of the work that we do is on this, and related to that is script training practice. So on the next one, there you can do a lot of social skills and script training practice for even daily interactions with friends and family members, for interviews, for interactions with community members and health professionals, self-advocacy, behavioral management or self-talk, disagreements, settling conflicts, etc. And again, this is not to turn them into, robotic productions of the script, but to get them something that provides a template for them that they can learn and overlearn, so that they can draw it out of their brain whenever possible, when they're under time pressure, when there's distractions, that can help them navigate these daily activities that depend so much on intact communication skills. Alongside these, we also do a lot of metacognitive language and discourse activities. So for example, we might simulate an interview and video record it, and then together watch the video, and we have different rating scales, and we'll kind of co-critique and look at areas for improvement, and look at what was good, and rate overall, rate overall cohesion, etc. Together. During the week, they may also record interactions with family members or friends, and they'll bring that information in, and we'll listen to it and critique it together as well. In some cases, we actually have a lot of bad responses to interview questions, or bad responses just to, how are you questions. And so they're kind of presented in a multiple choice fashion where, okay, here are 4 ways to answer this question. Which one's the best one? And why do you think that this one's good? Why do you think that these were bad? And then again, lots of ways to look at predicting how they think they're going to do in a certain conversation or a certain situation, and then actually doing that task and audio taping or videotaping it, and then seeing how well their predictions matched up with their ratings afterwards. And I'll bring this up again shortly. The next slide I just want to bring your attention to, because these are actually evidence-based recommendations for attention. So they're not listed under the cognitive communication domain. They're under attention. And I highlighted in orange for you, again, which one's most appropriate for making sure that while you're doing these attention tasks, you're also addressing cognitive communication deficits. And so metacognitive training for compensatory strategies, and foster generalization to real-world tasks. And the examples that I give you specifically, which again are from those recommendations, are mindfulness training on the next slide, self-alerting, time pressure management, goal management training. These are the main ones that can include a huge communication component. And we do, as speech pathologists, we do a lot of time pressure management and conversation. And so this is something that we already do. I know this is something that also neuropsychologists do. And if there's a way to do it in a way that also is, really fostering successful communication, then you're kind of hitting 2 birds with 1 stone, which is a terrible analogy. Why do we want to kill birds? But you're accomplishing 2 things. Someone give me another analogy for that one. So again, a lot of metacognitive strategies with this. And on the next slide, I give some examples. Some of the strategies too are, one more slide, asking for more specific information, asking for more specific instructions, advocating for themselves. So if they actually need some quiet, if they need someone to stop talking for a minute, making a written plan for how to complete the task, restating again the gist or the most important instructions. And along with these skills that we teach in time pressure management is verbal mediation, positive self-talk, inner or outer rehearsal, and a lot of self-pacing and self-monitoring. So this is a really nice way to show the convergence of cognitive communication and attention issues. And this next one is just a screenshot. It's given some examples of plans and emergency plans for time pressure management. So look that over when you get a chance. The next slide is a sample goal. So for example, the client will consistently implement TPM in the home for complex multi-step task completion. And it gives a couple of examples of the different levels that of course are working on attention, but are also working on cognitive communication deficits at the same time. And the next slide is another example, looking at accuracy and reading with distractions. So, this is another obvious way to combine the two, because we know that people need to converse when there's, music playing at Starbucks and there's people around. So working on tasks where they can do things that are related to language and related to communication while there are distractions is a perfect way to merge attention and cognitive communication work. So kind of speeding on to the end here, all of the executive functioning guidelines that are recommended by the Cicerone and by the ACRM, all of them can include work for cognitive communication deficits as well. So please, please, please include those. So I've included a couple of goals. This is, again, using problem-solving strategies with visual supports, and kind of talking about different solutions, why solutions were selected. The next one is identifying, again, metacognitive work, identifying in conversation when certain strategies didn't work, identifying when they did not stay on topic, when they didn't use an appropriate topic choice, and when they didn't take turns appropriately. So these are straight out of the executive functioning cookbook, but they're about communicating. And so a perfect way to make sure that that gets represented well across all of our disciplines. The next one is very common, the rating scale. If you could go back up one slide. This is again where, could you go backwards one slide? Yeah, this is just an example from a great workbook that we have where, there's a recipe to follow and they're going to predict how well they are going to do. And then they actually go through it and then they judge how well they did on that task. And you can do this with recipes all the way from something as simple as recipes to a conversation or an interview, anything like that. So this is a great strategy to use for executive functions as well as cognitive communication. This next one is a good workbook, problem-solving therapy program. They take a lot of communication abilities and deficits into account. Nancy Helm Estabrooks is actually a speech path, and she created this. And so it's nice because it merges it quite well. And then a couple more slides, deciding the first step in problem solving. And the next one is even better, I think, how to avoid problems. Some of our patients, most of our patients, just kind of rush headlong into the problems because their problem solving skills are not intact. And so even work on avoiding problems and doing it in a way that is also fostering communication, maybe even leading to development of scripts and role play, which will work on their cognitive communication deficits. This is a perfect way, again, to marry executive functioning tasks with cognitive communication tasks. So I just refer you back to the NCOG recommendation number 2. If they have a cognitive communication disorder, please refer them to a speech-language pathologist. And also please find a way in your tasks, if you're working on attention, if you're working on memory, if you're working on executive functioning or visual perception, any of those, that you're also, trying to find ways to include building up their cognitive communication skills as well. So the key takeaways are here. I don't think I need to read them. I think we can go straight to what questions do you have?
Touch me. That was fabulous. It's always a tour de force. You know, it's always good to see you. And I'm going to say it's always nice to hear, you know, speech. So, because you know, we're a lot of us are neuropsychologists, psychologists, counselors, and we just don't get as much speech people participating this time around. So maybe next time we'll get more of an integration. So. Why don't we take a few minutes, have any questions that people might have, and then we'll roll over to the case, and if we need more time for the case, we can go on the next time we meet to the case. So go ahead.
Jessica, how widely is the CCD understood by speech pathologists in general? Is it hard to find one who will evaluate a patient for this?
Thank you for that question. I think we have a generational training gap here. So definitely for a lot of our people who were trained a lot before 2000s, they're not going to be as aware of it unless they're, you know, doing the continuing ed. So we still have a lot of gaps there. You know, when I've gone out to train other folks, they're still giving only WAB, the Western Aphasia Battery, to see if they've got any problems after TBI. And so they're very receptive. So I feel like once, you know, we can reach them, that they're very receptive to it. But so I would say it's a training issue. And, you know, I'm getting older myself, so I don't want to say younger is better here, but we're teaching it now, and it was not taught. I did not receive this training, and I was trained at one of the top schools in the nation back in, and I received my degree in 2003, and this was not even hinted at. So,
thank you.
Other questions or comments?
Hi, this is Carrie. I just have a quick question. There's a lot of good information here. I was wondering if you could talk more specifically about confabulation and which of, if any of the exercises you talked about would be helpful with that one, because that one feels more even outside the box as far as whether the client is really going to be aware that they're doing that.
Yeah, that's a really good question. Thank you for that. So one of the things that we do with it is the metacognitive tasks where we are reviewing together. And we really kind of take a sentence by sentence, utterance by utterance approach to talk about the truthfulness. So relevance is one of the things that we'll rate, like, here's our overall topic. How relevant was the sentence to this overall topic? And then how accurate was the sentence? We don't say truthfulness, but how accurate was the sentence to this overall topic? Whenever we can do that with someone else, a family member or a friend who might also be bringing some other potentially more accurate information, that's always very helpful too. It can get very sensitive, and this definitely is where, especially if they, so we do have patients who are confabulatory and don't seem to recognize at all that they are. We do have some patients who are able to recognize it when it's brought to their attention. So it's kind of seeing where they are also in that categorization to determine what's the best approach with them.
Carrie, did you have any follow-up on that? Okay.
Not really. That's
okay. Let me add something to that, if you don't mind. You know, when we say confabulation, I always say BS, and then I mean, in the sense that what people are doing is they're baloneying people, right? Because what it looks like in conversation, it looks like they're just making stuff up in therapy. They say stuff, and you're like, where did you get that from? And so the things that Jessica is saying are really, really important. What I try to do as well is I try to then look at the neuropsych and figure out where the holes are and why that's happening. because that's when you begin to do your training around that as well. If it's attention and they can't remember what just happened, 5 seconds ago, then you have to slow down the discussion around that. If it's memory, then you have a bigger problem. And then if it's more executive functioning, where they really can't integrate information. So for me, I try to break down what is making them what's causing them to go and use confabulation of BS.
Mm-hmm. Mm-hmm.
And then underneath that, it can be also just the emotional issue of, I have a brain injury and I don't like it, and I don't like the way I can't process. And so there's a psychological component to it of just they're angry, or they're really depressed or hurt about what's happened to them, or they're hopeless. And so then they just start saying, no, it has to be my way. And then the flip to that is then you look at the family as well, as Jessica was saying earlier, about how they begin to either encourage that or begin to kind of ameliorate it so that it's not reactive to it. So then people learn to slow down and put in delays, and then begin to allow people to cogitate on what's going on, if that makes sense, Jessica.
Yeah, I think it's great. I mean, one of the things we also talk about in communication partner training is like, this is not personal. And it's hard to really get that across. And as, a family member of someone with brain injury, it feels very personal sometimes, but, just to explain the anatomy of the brain and the damage, and that this is not targeted to you. They cannot control it. So that's one of the important things with that. I just want to add to your reasons for the confabulation. You mentioned attention and memory. A lot of our more right hemisphere involved patients too, their perceptions, they are perceiving a completely different reality. So, we're calling it confabulating, but they're not confabulating. They're telling the truth. So it's, again, kind of finding where, that would not be a person that would be appropriate at that level at that point, because you're not going to convince them that their reality is wrong. It's not happening. And so I think, you bring up a good point. It's very nuanced, as is all of our patients. But yeah.
Yeah, and at some point, I think we should just have a huge talk on what to do when the right hemisphere is dinged, because I call that the silent brain injury.
Yeah.
Because, when your left is dinged, everybody knows it because you're not talking or something, there's something about language going on. But when that right is dinged, everybody's like, they look great. You're like, oh, we're just warming up.
Yeah.
So I just love to see just a right hemi kind of gig or something, or just like something right hemi. All right. Other questions, comments, things to add in there of what we just talked about? Okay. All right. Well, as always, we miss you. And thank you.
I'll stick around for the case.
Good. Fabulous. All right. So we're going to run through the case. I know we won't have enough time to get through it completely, so we'll also talk about following up so we don't have time pressure.
Right.
That's the way I've managed this craziness about how do we get this all to work. And so it's broken, and so we just try to work around it. All right. So I'm supposed to go to share. And then I'm supposed to go to that, and then I'm supposed to go to escape, and then close out of that, and then go to that. All right. Okay. So here we go. So this is Margot's case, so she'll